Hi, this is Andrea Kane, and I'm here with you for HIT 445 Quality Management. We are now on to week 3. This week we will be covering textbook chapters 10, 12, and 13. This is the lecture video on chapter 10. If you're looking at our syllabus, we are focusing on unit objective 9.5.5. All right, so let's take a look at our book. Page 175, chapter 10, Preventing and Controlling Infectious Disease. These are the learning objectives according to our book for this chapter. And we have some more here. It's really about reducing infections, preventing and reducing infections. So infections and infectious disease processes play a prominent role in the management of quality and performance in every healthcare organization. Consumers tend to avoid healthcare organizations that have high rates of healthcare-associated infections, and I would add here this caveat, if they know about them. Hospitals can be very good at hiding their rates, and consumers don't often realize that they may have a hospital in their area with lots of healthcare-associated infections. There are ways that they can go out and take a look at those, but unfortunately, that's not something that's very transparent these days. There are financial and emotional costs to patients and facilities that are increased when care is extended because of unexpected infection. When it comes to managing infectious diseases, there is usually an infection committee, and there is also individual responsibility. Typically, most hospitals have an infection preventionist or a department of infection control or infection prevention that is led by some nursing staff or someone with a background in nursing. Um, Ultimately, it is the organization, the entire organization's responsibility, but they work through the committee structure and also through a departmental structure. Weekly reviews of the facility-wide incidence of infectious disease should be performed, and sometimes it needs to be daily. You think about the COVID pandemic that we've had. I am quite sure that those I know who are currently in infection prevention or used to be, those colleagues that I worked with have been crazy busy keeping up with it. Infection management is usually based off of an infection control plan, and this is looking at what were the infections the prior year and how do we minimize those in the coming year? How can we proactively plan to reduce those infection rates, prevent some of those infections and things like that? So one of the ways that you can do that is through standard precautions. This is washing hands between patients, wearing gloves, gowns, masks, eye protection whenever you're going to be doing something that disrupts the patient's skin or mucous membranes. Or for instance, if you have a patient who is coughing or has an illness or disease that could cause um, air carried droplets to pass that infection on. If you have someone with a skin issue, where touching a patient could cause transmission of that infection. So anytime you have an infectious disease going on, you definitely want to use protective wear, personal protective equipment. You want to reduce the risk of health-acquired infections, and this means getting patients out from the hospital as quickly as possible, making sure that you don't have ventilator-associated pneumonia cases, that you're taking patients off vents appropriately, timely, and using proper protocol when you're handling patients on vents. Urinary catheter-associated infections. Trying to get those catheters out of patients as quickly as possible if you have to put them in the first place, and making sure that your hygiene when you're changing catheters, removing catheters, inserting catheters is perfect, that you are wearing a gown, gloves, mask and that you are doing techniques that use antiseptics or appropriate germ reduction um, activities. Another step is conducting ongoing infection surveillance and epidemiologic investigations. This is when, okay, now we've got an infection. We need to evaluate, how did this happen? Where did the exposure occur? Is this something that came in the community, or is it something that was acquired within the healthcare facility? And then who was involved? Who was exposed? Was there any type of employee exposure? Or was the employee the carrier? There have been incidences of hospitals that had infections, healthcare acquired infections occur, only to find out that maybe a staff member was a carrier and didn't know it, um, or was ill and didn't know it. Surveillance of vaccination programs, of the healthcare environment itself. Negative air pressure rooms, are those functioning the way that they should? If you have someone who's suspicious for tuberculosis, you've got to make sure that they're in a negative air pressure room and that that room is functioning that way, that it's pulling the air from the room up into the ventilation to be dealt with, not that it's pushing it out through within the hospital. Same thing in the ORs. If you don't have good control of your temperatures, humidity, and air pressures, negative air pressures in your OR, you can get healthcare acquired infections. So you have to be really careful with those. And then, of course, food prep. Same thing. You've got to make sure your employees are healthy, that they're following proper protocol when they're preparing foods, that the foods are fully cooked. I have a dear friend who has been a cook in a very large healthcare organization for, oh goodness, I think she's been there. She might be coming up on close to 30 years, and she would kick me for saying that. But anyway, it has been interesting talking to her about all of the different, over the years, it's been interesting talking to her about, from her perspective, the things that they do in food prep areas to prevent infections. So that's interesting and great information to know as well. Another step is conducting educational and screening programs, making sure that you're evaluating all the ways that things can be transmitted throughout the facility and educating. So many people just don't realize how disease can be spread and how they can prevent it. Making sure that everyone's tested for tuberculosis as appropriate. Hand washing campaigns. Hand washing continues to be the greatest source of healthcare acquired infections. And so it kind of boggles the mind as to why healthcare givers are not washing their hands consistently. Now, you say that, and I say that, and maybe we all think it, but I've also been out on the floor. And if you've ever followed around a nurse for even a couple of hours, you know they're washing their hands, they're gelling their hands, they're foaming their hands, they're putting gloves on, they're putting gloves off, they're foaming, they're gelling, they're washing, they're foaming, they're gelling, they're washing. They're poor hands. My mom is a nurse, and I know that for a number of years, when she worked in the hospital environment, and even when she worked in the physician office environment, she always had dry hands. She always struggled with dry skin and lotion and whatnot. And of course, you have to be careful with that because you do want the hand washing to occur, but at the same time, it's really difficult to have extremely dry, cracking hands. That can be an issue for the individual. So then it gets down to lotions. What lotions can you have on the units that are acceptable, that will help you with your hands and your dry skin, but yet at the same don't promote transmission of infections? So there's just so many pieces to this, so many moving pieces you have to consider. It's not just a matter of saying, oh, hand washing isn't happening. Why isn't it happening? What do we need to do differently? Are they having to walk too far to be able to foam in or foam out or gel in or gel out? Are the sinks placed poorly? Are the I can't tell you the number of times I've been up on a unit, and the one of the reasons the nurses were frustrated is that their soap dispensers did not stay full. They constantly were running out of hand sanitizer or hand soap, and they don't have time to go to a supply closet, get it, and stick it in. They need other people that are watching that. throughout the shift and taking care of that for them so that they can continue on with patient care. Then there's influenza vaccination programs. Of course, after COVID, it'll be interesting to see if enough people are vaccinated for COVID. Will that eliminate the need for influenza vaccination? There are some that speculate that will be the case. It'll be interesting to see how that rolls out over the coming years. Hepatitis B vaccinations for high-risk employees. Absolutely. If they're exposed to an area of blood-borne pathogens, that's a good investment in their time and effort to get those vaccinations to keep them healthy. Sterile technique in services. Constant need to go back over with people how you gown and glove to go in, how you take it back off, so that you're not spreading those germs, and you're not taking germs with you into the patient's room. That constantly, every year, is something that needs to be gone over with staff. And not just nursing staff, housekeeping staff, and anyone else who goes into patient rooms or cares for areas where patients are, including maintenance. If maintenance have to go into, if a maintenance person has to go into a patient care room where there's someone that has an issue, they're going to have to gown, glove, the whole 9 yards, depending on the situation. Needle stick prevention programs. Unfortunately, there are still some caregivers who put syringes on the bed and forget they're there, strip the bed, and then the poor housekeeper ends up with a needle stick. That continues to happen. So how do you do that? How do you make sure? Sometimes they'll do a bedside procedure and they'll drop a syringe somewhere where somebody else runs into it. How do you make sure people understand that anything that's touched a patient that has a sharp on it or a sharp end on it, it gets where it needs to go so no one else is put at risk? How do you get that to be second nature? And then universal protocol education mandatory for all employees. So a QI toolbox technique is flowcharts, and those are used to represent standard functions within processes. And do they give us an example? Yes, on page 183, they tell you what is a process icon versus a decision icon versus a predefined process icon versus a connector icon versus start and end icons, and on and on and on. And then they give you an example of a flowchart. That's figure 10.2 on page 185. Oh, and look, they give you more. There's 10.3 on page 186, 10.4 on page 187, 10.5 on page 188, 10.6 on page 189. So yes, you can go and see flowcharts to your heart's content and what all the symbols mean and how you would use them. And that is the end of chapter 10. I will be back shortly to talk to you in another lecture video about chapter 12 and then one after that for chapter 13. Have a fabulous week. But don't forget to watch the other videos.